Corneal transplantation is a surgical option to treat corneal disease that has caused opacification of the cornea. Corneal transplant is no longer one size fits all, whereas 10, 15, 20 years ago, we used to perform full-thickness corneal transplant for any corneal disease that caused opacification at any layer of the cornea. We now directly target that layer that is diseased. So let's break it down. There's really 4 different types of corneal transplant. Penetrating keratoplasty or full-thickness transplant is still an option, although now in my practice, that is the least commonly done corneal transplant because it's reserved for those cases where every layer of the cornea is diseased or that there is a laceration in the cornea that's central to the vision. But for cases such as Fuchs dystrophy or pseudophakic bullous keratopathy, where the corneal endothelium is the layer that's diseased and the other layers are perfectly normal, in that case, I then target the treatment to the disease layer. We perform DMEK, which is Descemet's membrane endothelial keratoplasty, for those patients who have Fuchs dystrophy or pseudophakic bullous keratopathy and otherwise healthy eyes. DMEK is essentially replacing exactly the layer that's diseased. So I strip the cornea of its diseased endothelial layer and Descemet's layer and take a donor cornea and strip the donor of Descemet's and endothelium and transplant the healthy endothelial layer into the recipient. With DMEK, the vision recovery is much faster than any other approach in cornea, and the rate of rejection is much lower. It's not unusual in my post-DMEK patients that they'll reach their vision potential within a month. That can be as best as 20/20. DSAEK, which is Descemet stripping endothelial keratoplasty, is a version of endothelial keratoplasty for a patient who is not a candidate for DMEK. These are patients who have pseudophakic bullous keratopathy or Fuchs, but have other diseases such as glaucoma or have disrupted anterior chamber, if they're iris defects, they have tubes and shunts for glaucoma, or have a very opaque cornea through which I wouldn't be able to visualize the DMEK graft. And finally, deep anterior lamellar keratoplasty. That is a corneal transplant where we replace the anterior layers of the cornea for diseases that affect the corneal stroma and the surface layers and leave the endothelium intact. So it's really the reverse of DMEK in that the Descemet's and the endothelium in these cases are healthy, but the corneal stroma is diseased. The classic type of patient who would be ideal for deep anterior lamellar keratoplasty would be a keratoconic patient or a patient with ectasia. I typically like to use a laser to create what's called a zigzag incision and perform the deep anterior lamellar keratoplasty. The benefits of the DALK surgery as compared to penetrating keratoplasty that most surgeons offer keratoconics is that because you leave the endothelium intact, the chance of rejection is really eliminated, and these patients can enjoy excellent vision after their corneal transplant has healed for really the rest of their life. So as you can see, corneal transplantation has evolved in the last 10, 15 years, and I'm really excited to be able to customize the surgical option to every patient in such a way that gives them the best vision outcome possible.